Yes, I encourage we say like in the reality we'll think more about the diagnostic, like we call it differential diagnostic.
Since you have a question, I also have a question for you.
Yes.
What GI disease associated with primary sclerosing cholangitis?
Yes, we say.
Sorry, the question for everyone too. So everyone knows. Just raise your hand.
Can you ask me again?
There is a GI disease that is strongly associated with the. I'll answer right here. What's the name of it? Do you know what's the name of that disease?
What the name of the disease related to PCS, right?
Yeah, it's a brother of Crohn's disease. That's
Crohn's disease. Yeah.
It's the brother of Crohn's disease, not Crohn's disease. It's a brother of Crohn's disease. It's in the same class as Crohn's disease.
I see. Ulcer colonitis, right? You see, yeah, you see.
Yeah. Yes. Yeah. Good. Good. And it's also associated with what type of cancer? Sorry, just like association.
Pancreatic cancer.
Close. Also start with a C.
Also, start with a T.
A C. What was that?
Colon cancer.
Angiocardinoma. That's very strong association. They asked that on step 2. So cholangiocarcinoma, PSC, and ulcerative colitis is like 3 things that always go together. So good to know. It's rare though. You don't see it that much, but it's there. Sorry for taking up your time too.
Yes, again, like the PCS related to UC, like ulcerative colitis. It is also related to another cancer. So which is about what's again the name again, Mr. Leo?
Cholangiocarcinoma.
Carcinoma, yes, cholangiocarcinoma. So you think about this, the couple of disease go together, okay?
But, maybe this patient has, who knows?
Okay, so that's very interesting part about this first question. So now we can come to the next question. Other things we can read from here. So let's start with someone who can help me to read that question. Why? I didn't see you talk anything. Go ahead. Hi, hello. Where are you?
I'm here.
Yes, please help us to read the question and say something.
Yeah, I don't have idea about this case.
No. I'm asking to help us read the question. Just read the question first and don't say anything.
Yeah. I don't have idea. Yeah.
No, please read just read it.
Yeah.
72 years old. Yeah, just go with that.
Yeah. Read that?
Yes, please.
Yeah, just read the question. You don't need to know the answer.
72-year-old man is about to the physical by his son because of gradually progressive yellow discoloration of skin and
generalized pruritus.
temperature for the past 2 weeks
Mm-hmm.
due to the period. His,
Mm-hmm.
uh,
Appetite. Yeah.
his appetite has decreased and he has uh, 6.3 kilo
Mm-hmm.
weight.
Lots. Yeah.
Yeah,
Yes.
he reports that his soon appear and his urine is very dark. 3 years ago, he had an episode of acute upper uh, abdominal pain
Yes.
that were treated with IV fluid
Mm-hmm.
and SAIDs,
And said, yeah, you can read and said, yeah.
yeah, in class, and dietary modification.
Dietary modification. Dietary modification.
Dietary modification. He
Yes.
has stopped drinking alcohol since then.
Mm-hmm.
He used to drink 1 to 2 a day for 40 years. He has
Mm-hmm.
smoked a cigarette daily for past 50 years.
Mm-hmm.
His vital
It's
signs
vital sign. Vital signs. Yeah.
are within normal.
Mm-hmm.
Physical examination show yellow swing of conjunctive and
Conjunctivate. Conjunctivate. Yep.
conjunctivite and skin.
Okay.
Abdomen is soft and non-standard. Soft
Non-tender. Non-tender. Yeah.
and tender. Soft system of
Mm. Palpatic. Yeah.
palpatic in the right upper
Quadrant. Quadrant. Yeah.
quadrant. Serum studies show
And you can skip that table and you can read the next line. Yeah.
thank you for listening.
Yeah, it's okay. And yeah, you can help me finish the last sentence. Abdominal ultrasound.
Abdominal ultrasound saw an
Anechoic. Anechoic. Cystic mass.
cystic mass in the subhepatic region
Yeah. Yes.
and vital
Intrahepatic. Extrahepatic bile duct. Yes.
by the which of the following in the most likely diagnosis?
Yes. Thank you so much for your efforts. Yeah, just try to practice. Don't worry. Okay, so we have the next question, and it's also related to something about this problem. So let's see what we have. What we have abnormal here? Who is Long? I didn't hear anything from you now. Long time.
Abnormal is he has a gradually progressive yellow discoloration of his skin and generalized pruritus for the past 2 weeks. His appetite has decreased. He had a weight loss. His toe appear pale and his urine is very dark.
Okay, so patient in here also have the decreased appetite and weight loss, right? This is something that suggests about a systemic symptom for a malignant condition. And anything else about Vong? Can you say something like about some symptom you think the patient have, and can you think what meaning of that? Yeah.
I think this patient may have obstruction of the bile duct.
Obstruction in the bile duct. Okay.
Yes.
Okay. Thank you, Long. Again.
Because I think he had obstruction in bile duct by a malignant tumor.
Okay.
He had a yellow discoloration of his skin. He has weight loss. His stool is pale and urine very dark.
Yeah. Okay. So another idea. How about Vong? How you think? Like something you explain some symptoms here.
Well, let me see. I think that an important symptom is a mass at the right upper quadrant, like the patient before, and this patient also has a mass, and also abdominal ultrasonography show that there is a anechoic hepatic cystic mass, right? Right. The relation in both intrahepatic and extrahepatic.
Okay. Okay.
Yeah.
So what the meaning of the dilated intra and extrahepatic? Like what the meaning of that?
Well, I think that there is a obstruction.
Where's obstruction?
Outside the liver.
Yeah.
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 Now,
like we call like biliary tract obstruction. Yeah, we can say like this biliary tract obstruction.
Biliary. Yeah. Biliary.
And when we see like anechoic subhepatic cystic mass, what the meaning of that? What you suspect in your mind? What is that? Any idea for that? What is that?
Subhepatic region. We have a mass in subhepatic region. That made me think about some tumor from the hepatic region, the subhepatic, like from the hepatic, from the pancreas, or even from the colon, the kind of the right colon.
Right colon. Okay, but we see like here we should have the anechoic subhepatic cystic mass. What in your mind, like the most thing in your mind now, like which is that?
I think
go ahead.
I think the most thing I think in the cystic mass in this reason I think about the gallbladder.
Yes, that's a gallbladder.
Yeah, this is the first I think.
Yes,
because we have the dilation of the intra and extra hepatis. So
correct.
It means that maybe the gallbladder is the same.
Yeah, it's the distended. We're calling it distended non-tender gallbladder.
So
exactly.
Why you don't think about the pancreatic head tumor?
Because we have the many properties of the gallbladder like anechoic. It means that it is a solid. It is no solid. It is a
non-solid. You can say like this.
Yeah, non-solid and the soft. When we
soft. What we say? Soft, right?
Soft. Yeah, soft, non-tender, and ultrasound says that is anechoic.
Yeah, anechoic. Yes.
Anechoic. So all of them make me think about the gallbladder more than another tumor because tumor is maybe it's echo or we have the more solid tumor is
Okay, we need to differentiate here. Like when we see that mass, it doesn't mean like this is a tumor or doesn't mean like this is a cancer there. Sometimes with the obstruction, like when you see the obstruction, the part of the system can be dilated. And this we can see on ultrasound with the another thing, another cause. Like, so now we need to think like which obstruction and which is the complication for that, like the cause and the complication. So we need to differentiate between them. Like, we cannot make conclusion like that's problem from the gallbladder, or it's not problem from the other thing like pancreas or another part of the disease, like upper, what we call like, that reason. So we cannot say like this. Like, we need to differentiate like with specific thing now. Okay, so let's see the lab test. But we can see patient have the increase both the bilirubin and direct bilirubin, total and direct bilirubin means they have the obstruction, as we call like indirect hyper what do we call like hyper conjugated hyperbilirubinemia. Yeah, we call like this name, conjugated hyperbilirubinemia. Yeah, it's a direct bilirubin. So let's see about the option, what we have here. We have lots of options, make us confused. So what do you guys think? What do you guys think? Who's want to say, talk? We have a new member here. I don't know, you, right? Yeah, I don't know. Okay. Who wants to talk about this? Okay, Anh Hoàng, how do you think?
Yeah. In this case, I will summarize a little. Yeah. In this case, the patient have some problem, and I can summarize it like this. As first, he had the urine wall duct and the stone wall pale. Make me think about the obstruction of it by duct. And the yellows of conjunction skin jaundice, and make me think about the increase of the bilirubin, and this confirmed by the serum test. Yeah, and when we do the examination, we can see the mass, cystic mass, soft cystic mass. So, and the ultrasound have the anechoic cystic mass. So I think it is about the gallbladder. The extender of gallbladder. So on of them make me think about the obstruction of bile duct in the hepatic bile duct. Yeah. And one more thing about is AST and ALT is normal. Yeah. So I don't think the reason from the hepatitis.
It's from the liver, right? Yeah, from the liver. Yeah.
So this case, the acute cholangitis. I don't think about the acute cholangitis.
Cholangitis. You can.
Cholangitis.
Cholangitis. Yep.
Alcohol hepatitis. No.
Okay.
But so the most.
So what the most likely in your mind now? What? Yeah, the most likely in your mind now. So just say that. Yeah, don't worry. This can be right.
We have two options. One is A, pancreatic adenocarcinoma, and Z, pancreatic cirrhosis.
Cirrhosis. Oh, yeah. Okay. How about the other idea? Yeah. You have 50% for.
No, not 50-50. But so maybe 70 and 30%.
What is 7? What's the 70?
Maybe pancreatic adenocarcinoma is 70%, and
when you are in the test, you pick That's the option,
Yeah,
right?
yeah.
Yes, okay. Okay, yeah. But in the test, you don't have time to think a lot, and you should make the decision very directly.
Okay.
Yes, thank you so
Yeah.
much. And how about another choice, another idea? The same, or you guys think is the option? That is the answer?
I also think that the more suitable answer is A. With the G, pancreatitis cirrhosis. As I read, it actually a kind of fluid collection that is contain a pancreatic enzyme, right? And that often occurs several weeks after acute pancreatitis. This patient have the history of an episode of acute upper abdominal that treated with IV fluid and dietary modification. I think that it may be a kind of acute pancreatitis in the past, but it happened 3 years ago. So it made me kind of subtract the answer G.
Yeah.
And yeah. And
So
also
Mm-hmm.
this patient is at 72 years old and have an unreasonable weight loss. So that's the reason why we should think about malignancy.
Mm-hmm. Yeah, and one more thing about pseudocyst from the pancreas, and like this really rare compression, like biliary compression with the pseudocyst. I just looking for this information. That reason why in the first question we cannot think about it. Like it's very less likely to think about the pancreatic pseudocyst. It's really rare to make the compression in biliary tract. Like it cannot. It's easy to make compression. So something like about a tumor is like can make compression, and you see in this case patient have. And also like when said with the patient have the acute pancreatitis, or we call like acute on chronic pancreatitis, it can make pseudocyst, like the complication, common complication pseudocyst after a patient have the pancreatitis. And actually the patient don't have pancreatitis at all. Like it's a very long term, and like this patient we very highly suspected the patient had the pancreatic like tumor, or we call it a malignance. In this case, we suspected the patient had the adenocarcinoma. Okay, with all of the things we see here, and like likely we suspected, that's the answer. And you guys choose correct. Oh, you guys really good when you choose the same question. Usually, it's really nice. And so, any question from that?
Actually, in this case, because we have to choose in this answer, so that pancreatic adenocarcinoma is the most
Closest.
Yeah, closest. But actually, in clinical, there are another diagnosis like this. For example, I saw some patient with Volter carcinoma. Do you know?
Yeah, I know that. Volter.
Yeah. Well, they don't have any just obstruction of the bile duct.
Yeah.
And with the ultrasound and examination, we don't have any another findings.
Yeah.
So,
Yeah, but like we need to combine all things together. And actually, this patient have the very highly risk for the past medical history. Patient have the cigarette smoking.
Okay.
That's one of the most common cause for the risk factor for pancreatic cancer. Like we suspected, think about this. And like for the thing you say, like we call like ambulance of Walter. Sometimes we call about Walter carcinoma. Like this thing can happen, but it's rarer than about like pancreatic adenocarcinoma. But we cannot rule out this. And in that time, we have to looking for about this until we can confirm this that's a direct place like for the cancer. We confirm this until we can confirm. Yeah, so in we know that in the clinical practice, we usually think about the most common thing first, and then we think about another thing step by step, right? based on the symptom and based on the hours, like the gala, some kind that suggest us to make the diagnosis in that moment.
Yes.
Yeah, I agree with you. Okay, so I have.
I have one more question for everyone.
Yeah.
For 2K, we have the one thing is the lost weight, and we see. But I have question is this unusual for them to lose weight? They say that they lose weight very fast and they lost weight not slow. But I don't know which one.
You mean like significant weight loss, like right?
Yeah. When we say that is the unusual, and when we say that it is normal weight loss.
Yeah. So anyone know about this? That's a question. Yeah, interesting question.
In two cases, one person has weight loss 4.5 kilogram and one person weight loss 6 kilogram. We say that it is abnormal.
Yeah.
But when we say that it is normal.
So, according to American Cancer Society, an unexplained weight loss of 10 pounds or more will be considered a malignancy sign.
10 pounds?
10 pounds or more.
10 pounds for how many times?
In 6 months. Within 6 months.
6 months?
Yeah.
Very long time.
Well, yeah, but I don't lose that much weight in 6 months. I wish. I'd be thin. But then the guideline is if you lose more than 5% of your total body weight, it's not only need to be 10 pounds, 5% of your total body weight in 6 months. Then we think about malignancy. Yeah. Let's say patient is 300 pounds or 160 pounds, 5% will be 8 pounds. So 5%. 10 pounds is not really a lot.
10 pounds is around 4.5 kilogram. 4 kilogram. Around 4 kilogram. But 4 kilogram with a person around 100 kilogram is not a problem.
Yeah, that's why we say it's 5% of your body weight. So
yeah.
They based on the first percentage.
The
kg.
But,
and they define like if you weight your weight is lost more than 5% over 6 months. This we call like significant or like important weight loss. Yeah,
it doesn't really mean that you have to have cancer to have that weight loss. It means that's some metabolic problem. Something causes your body to consume more weight. Cancer could consume more weight. Hyperthyroidism could consume more weight.
Yes.
Estrogen sometimes can.
Or even patient use the medication to lose weight too. We don't know.
Yeah.
Yes.
We just say that this is abnormal or unusual. It don't mean that this is the cancer.
Yeah, we cannot say like direct the cancer. It can make the patient which is like likely make us pay attention. Yeah, maybe patient have any problem there.
Cancer should be on your differential diagnosis.
Yes.
Yeah, maybe it's in my hospital. Maybe it's not the guideline, but in my hospital, many people said that it's around 10% for 3 months.
In your hospital?
Yeah, 10% for 3 months.
They may go harder because they probably don't have people.
Because some patients come with us with the medical history. Medical history is very short. It's for 6 months, so we don't know.
Because probably in Japan people are thin, so that's why they use higher numbers. In America, we see fat people everywhere. So.
Yeah. For us, I think it is right because for maybe Western person, the weight is very high, maybe around over 80 kilogram. So 5% is okay.
Yeah.
5% is very
Yeah.
yeah.
Yeah, I agree.
But with Asian, 5% is very small. Because
Yeah.
maybe some person have the 50 kilogram.
Yes.
50 kilogram. It means that 5% is
2.5 kg.
2.5 kilogram for 6 months.
Yeah, it doesn't matter, right? Yeah, I agree. Yeah.
So maybe
that's
in
why history is
yeah.
important. History is
in my hospital we use 10% for 3 months. Yeah, I don't know if this is the guideline or not, but many people say that. Yeah.
So yeah, I agree with you too.
That's why
really...
history is very important. Okay, history.
Yes. We cannot base on one factor, or this can make conceive like you can conceive about the disease. Yeah, just that. So here that's a CT scan of the abdomen CT scan of this patient. You can see here. So I cannot describe it. You can see the abdomen will have the mass, and this mass can compress about the biliary tract and the make those of symptoms for this patient, and it's also in blue about this case too. So you guys can take a look at this.
So this PT, let's see, we see a couple cysts on the kidney on the left. We see the kidney on the right is normal. There's a couple of stuff in the liver, and there's a big mass right there in the middle of the liver, right at the head of the pancreas. If you see the pancreas,
yes.
The tail of the pancreas is there. You're following it.
Yeah.
On the right is just bowel gas and fecal materials in the bowel, so nothing there to see. But yeah, that's a big mass right there.
Yeah, that's the description for this abnormal.
We have the radiologist here, you know.
No, today we don't have him. Like he's gone away.
He can tell us like exactly.
Who is he? I forgot.
Thuong.
Thuong. Yeah.
Thuong, yeah.
Dr. Thuong. Yeah.
All right.
Okay. Yeah, this is very good. And here we have some information. I just try to give you guys about some risk factor for pancreatic cancer, and you can take a look at it. And like you see, they highlight this most important thing about the smoking, about the high alcohol consumption, and another thing, chronic pancreatitis is the most common risk factor for the pancreatic cancer. They do I talk it's based on the research. And another thing, and you guys can take a look at, is about the location of the pancreatic cancer. And we have the 3 places, and we call like pancreatic head, or a body, a tail. So the most possibility happen in the head of the pancreas. And another thing about we divide 2 things about the pancreatic exocrine tumor and pancreatic endocrine tumor, and you guys can take a look at it too. So the most common is from the pancreatic exocrine tumors, and this is mostly ductal adenocarcinoma. Yeah, and we see in this case patient number 2, and this patient have the suspected patient can have the pancreatic adenocarcinoma. Okay, so all the information I can give to you guys about this topic. Okay, so you guys have any question about this? Okay,
I have a question for them. Sorry, every time I have a question.
So interesting. We have a lot of questions, and we try to figure out the answer based on that.
So this is just a quick question. Usually, pancreatic cancer don't go alone. So what syndrome does pancreatic cancer associate with? This is an endocrine question. What?
Endocrine, yes. Do you know what this?
Yeah, if you know what it is, I will call your professor and tell them that you pay attention in class. It's very interesting syndrome that associate with pancreatic cancer. Start with an M.
Man.
Oh yeah, man. What type of man?
Okay, I was thinking what type man. So we have 4 type men, right? We have men 2A, men 2B, another man is about men 1A, right?
There's no 1A.
Yes. So, which is the main half the pancreatic cancer? And I want to make a
So
conclusion.
I'll give you a hint. It's all start with a P. Pancreatic cancer. The other two
Parathyroid,
also
yeah.
P. Parathyroid cancer. And what else? Pituitary adenoma.
Pituitary adenoma, yes.
So
So this is the main.
Come with 3. MEN type 1. I
Yeah.
will type it in the chat.
We call it MEN, yes. Multiple endocrine neoplasia type 3.
Yeah, usually if you have pancreatic cancer, you have to think about MEN type 1 because it's usually associated with that. And the 3 together is called multiple endocrine neoplasia
Yeah.
type 1.
Yeah, type 1.
Do you know what cancer is parathyroid?
Parathyroid.
Hyperplasia.
For parathyroid, which is called the cancer in there, right? No, it's not like that.
No, that's MEN type 2.
Type 2, yeah, I'm going to say. With in the parathyroid, I think like we call like what is just like
medullary, but
bit.
just parathyroid. I'm sorry, it's just parathyroid.
Yeah, just parathyroid. We call like primary hyperparathyroidism. Patient just have that as a symptom.
It's just an incidental finding. What's the most common pituitary cancer?
Pituitary cancer, but pituitary adenoma, right?
Yeah, but what's the most common pituitary adenoma?
Prolactinoma.
Prolactinoma. Why you answer for them? You already answered everything.
Sorry. Okay, because Mr. Leon, I want to say something. Because for those of students studying in Vietnam, in university in Vietnam here, they didn't teach us about those of things like this. So I know when you ask the question, I guarantee they do raising, motor raising.
That's fine. Now they know they can raise their hand in lecture and impress the professor. Make sure you do that.
Yeah, that's it. It's the extra information about for some syndrome. Yeah, we have the group of cancer go together, and when you see the patient have the cancer, you should looking for another cancer. Maybe patient have that another cancer too. They go together. Yeah, and they call like with the name here. What was it? Multiple neoplasia.
Neoplasia.
Yeah.
So good case. Yeah.
Yeah.
So a lot of things to talk about. That's why I say it's really hard.
It's really hard, but you see, we also have some information about this disease, and I think like the main purpose here, we didn't go to direct about make the clinical diagnosis or some kind of or about the lecture. We just try to discuss and practice speaking, and that's the main purpose here. So you guys try to speak more and more next time. Okay.
Yeah, don't be scared because most of the time in clinic, you won't be the one who diagnoses. The GI doctors will be diagnosis. So if you go to a general practitioner like me, I'm going to family medicine. I won't diagnose this. I will send this patient to someone else. So if you become a GI doctor or radiologist, this is fun to do. So one tips, I haven't seen a lot of people talking today, but I hope you guys can talk a lot next time. Thuong, you done?
Yeah,
right?
sorry.
Really good case.
Good case. Okay, thank you so much for your idea.
Sorry.
So it means like the good case means the hard case, right? Okay, so in next time, I think the good case in me, we can discuss more based on this case. Like we can learn something from that. So in the future, next week we will do another talk about another topic. I hope we will. So do you think we should change another field?
Do you guys want to do cancer?
So you guys want to keep continue
Years
doing
ago,
cancer? Cancer?
What topic you guys want to know? Like,
Yes. Okay. Choose another because I feel like cancer all the time make you guys feel like so.
and
What
we
is
do
cancer?
cancer for 2 months already. Like,
So
what
let's pick
topic?
something.
Any idea? Vâng, what topic you want to learn more? I haven't heard you talk, so I just want to pick on you so you can talk.
Oh, well, I think that I just learned a bit about the clinical and I don't have any experience. So, okay, maybe
What
other
topic you
members.
weak at in school? Like, what do you want to know more?
No, I'm not sure. I think that other members will have a more interesting choice than me.
Okay. So you're strong at everything. Okay, that's good. That's confident. Doesn't anybody want to do something like cancer again? Okay, I guess.
So let's try. Okay. Anh Hoàng, I think Anh Hoàng will suggest we do the cancer because he's a field like.
Not
right?
cancer. Okay, yeah, alright. We do cancer.
Okay.
Pancreatic
But it
cancer.
depends. Okay, now we will discuss about which kind of topic.
we can say about we can continue to with the cancer topic, but we focus on the clinical and examination, something like that, not to do the treatment or maybe more.
Yeah, I agree.
Yeah, we can discuss many things in this case.
Cool.
Yeah.
So it's no problem.
Yeah. I think we can next week we will discuss about which kind of topic we want to deliver. If you guys don't pick, we will pick, and maybe it's cancer, maybe it's not cancer.
Maybe
so
we
let's
can
choose.
make a vote on the website and everybody can just vote.
Oh yeah, that's really nice. Yeah, we will make the book. Yeah, we can
finalize it by Wednesday so we know have time
Yes.
to prepare.
Yes, and we will prepare for that. Okay, thank you so much for you guys. We
Thank
spent
you,
1.5
everybody.
hour. Yeah, 1.5 hour together, and this is a weekend, so stop the show here
Good
and go
weekend.
enjoy your weekend. Yeah, enjoy the weekend. This
Go
weekend.
enjoy your
now.
life. Go have fun. Go to the bar. Drink some beer or whatever. Don't drink too much. Or you have
Maybe I will go out and drink something.
Don't drink too
Just
much.
kidding. I'm just kidding. Yeah. Okay. Bye bye. See you guys next week.
Anytime. Don't do that. Okay. Enjoy your life.
Yeah.
Bye.
Bye.
Bye bye.